It is the World Health Association diagnostic. So it lines up with the ICD 11. So instead of having that GAF, now we use the HUDAS. Okay. So prior to that, the GAF was that global S6 functioning. We give you a scale based on how you're currently functioning. This one we'll use in place of that, and it's really an overall generic kind of health screening. So then a physician and a psychiatrist should get the same kind of mental health the same kind of physical diagnosis at least. Okay. So let's talk about some of those big diagnoses. So if I ask you about bipolar 1 and bipolar 2, what's the difference? You're right. Thank you. Come on. Give me some feedback, guys. So in general, my bipolar 1, okay, has more of the high days. When we think of bipolar, when you see the commercials on TV, it's almost always bipolar 1. That's what we think of in general when we think of bipolar. So what you'll notice is on my bipolar 1, if you can, the kind of colors look the same, the bipolar 1 is at least a week of that full-blown mania. We're looking at 5 to 7 days of not needing any sleep. If I could pick a disorder and not have the side effects of it, then I'd pick that mania. You like think you're on top of the world. You don't need sleep. My house would be clean. I'd like bake casseroles for everybody from now until whatever. The downside is you do some, shopping with money you don't have, maybe some gambling, maybe some sex with people you would normally have, but you think you're awesome. You're just on top of the world. So that's what my bipolar 1 looks like. So I've got at least 5 to 7 days of that full-blown mania. I have a client who, when she was little, told me about her mother would pick her up. They would pick her up from school, and they might like take a plane to like Paris. She lives in New York, and not having her dad would not have any idea. She's old enough to not have had cell phones back in the day, and her dad would have no idea where she was. Mom would then crash and she would be asleep for several days, and kids at this time was like 6 or 7 in a strange city and had no idea what was going on. So that's what it looks like, full-blown manic. I'm sure that you know the higher the high, the lower the low. So if you watch my little line, you'll see in order to have that diagnosis of my bipolar, I'm way up here for a week, my full-blown mania. Then I'm gonna crash. I'm gonna crash. So less than 2 weeks, right there, but I'm going all the way up, all the way down. Okay, that's my bipolar 1. And not on the test, but just for general information, we have people who are rapid cyclers, and you could see that in one day. With people who are seasonal cyclers, who, in the winter, this is what it's like. In the summer, this is what it's like. So average, we're looking at those time frames, and it's always up and down, no leveling off. It's always this way. Okay, those are my bipolar 1s. My bipolar 2s, if you'll see, they have a little bit less of that mania. They have a hypomania. Was that more or less? Less, you got it. Hypo means less, hyper means more. So when it comes to, the thyroidism, hypo means I'm not producing enough. Hyper means I'm producing too much. So hypo is less. So with my mania, then I really am going to have 2 to 4 days of hypomania, not up here, but up here. And many times my hypomania might even go undiagnosed because, Pam's in a really good mood a couple of days out of the week or a couple of days out of the month. She's like in a really good mood, but not enough to not sleep, or I might need less sleep, but I'm not having a full-blown manic attack. And again, you'll see that it goes down. I still get that depressive cycle, but when I get my high, I don't get near as high as that full-blown mania. Okay? Cyclothymia, I've always called it baby bipolar. And then a student said to me, is that what babies get? And I said, well, I guess I should probably not call it that. But it's a milder form of bipolar. So if you see, my cyclothymia is kind of here. I don't get that extreme depression. I don't get the extreme highs, but I'm still pretty moody, up and down, up and down. Okay, that's my cyclothymia. This one says unipolar as opposed to bipolar. Unipolar is just depression. Not just depression, but it's depression. So my unipolar then is only going to give me those lows, but not those highs. So that is depression. Um, there's a couple of new ones under depression we'll talk about in just a minute, but there's also, okay, the treatment of choice for lithium. The treatment of choice is lithium. That's the first choice. Lithium is the one that you have to get blood checks because you can definitely get some lithium poisoning levels. The second choice for that would be what? Anybody know? Come on. Somebody's being brave. Shalonda? She's typing slowly. My second choice most often is one of my anti-seizures. So I might see one of those as a second choice, or people who can't take lithium. That's what you would see sometimes to again stabilize those moods. Okay. That would work. Yep. Okay, so then I also have schizoaffective disorder. So that's a combination of a bipolar and then full-blown schizophrenia. So schizoaffective or schizoaffective is a pretty common diagnosis. So imagine, having those moods and then having the craziness. So you can hallucinate, have delusions in bipolar. So people who've not had any sleep, or who have had too much sleep can hallucinate. They can see things. So that's not uncommon to have a psychotic episode on either side of that. Not uncommon. However, to have it at the same time, that's what I'm looking at my schizoaffective disorder. Okay, and you can see it's characterized by the symptoms of schizophrenia. You got the hallucinations, the delusions, and then the symptoms of a mood disorder. So all the way up, all the way down, you are everywhere. Okay, so imagine having like command hallucinations, and that's what we have sometimes, and then being in a full blown like manic episode. It'd make me a little bit crazier. So if you can see the difference there. So my schizoaffective disorder, it's primarily the schizophrenia, but it has the symptoms of the mood disorder. The mood swings. I'm not having that in schizophrenia. I'm not having those mood swings. Okay. It can be treated with mood stabilizers as well as antipsychotics if I'm looking at my schizoaffective. So many times you're on a combination of both. That's how it really kind of keeps those things together for you. So in general, when I talk about psychotic disorders, I'm talking about hallucinations and or delusions. So difference, anybody? Not talking, are we? Thanks, I appreciate that. Be brave. Come on, come on. Okay. So my hallucinations often are things that I can see. If you're not going to speak, can you mute yourself? Mute you. here. Okay. Do you hear me? Okay, gotcha. Okay, better?
Yes.
Thank you much. There we go. Did you miss my whole hallucination about Barack?
Yes, we did.
Oh. Well, let me tell you. So my delusion is that Barack Obama is in love with me. He's been in love with me for many years, and he's just waiting for Michelle to leave, or it come, whatever they do, so he can come and stay with me. That's my delusion. My delusion of grandeur is that he's gonna we're gonna move to like Canada, and then he's gonna be like the prime minister there, and then I'm gonna be his wife, and we'll live happily ever after. That is my delusion of grandeur. Okay. My hallucination is that he's sitting here. Don't you see him? He and I are talking, having a great conversation. That's what that means. An idea of reference, which is a delusion, is when I think that maybe he's talking to me. So he's not on TV much anymore, but he's on TV, and he may be talking about, um, anything about the politics, or he's talking about anything about his wife and kids. And what I hear is when he mentions family, I hear him saying, Pam, I can't wait for you to be part of my family. I need you to come with me. So an idea of reference is taking a little bit of that truth in there somewhere and then making it fit my craziness. The most common ones are biblical references. It's not funny, it's true. I love him. I do. I'm pretty sure that, like, anyway, the CIA may be listening, but so then, speaking of ideas of reference, I really, really, especially when he was in office, I've had a thing for Brock. He came to Chattanooga one time. I'm pretty sure he just came to see me. And I've always made the joke that I'm pretty sure on the CIA list somewhere. One of my friends, her daughter actually worked on his security team, and I have a Christmas card. I'm sure he wrote it just to me. But I share this with all of my students. So I had a student a few years ago who then I got a call from the hospital warning me to be safe. He had taken that idea, my joke, what I always talk about with Barack, and he was very sure that the reason he was in the hospital was because the CIA was looking, it was the FBI, I think. The FBI was trying to get him so they could find me. So he was trying to, so he took that little idea of reference, my thoughts of Barack Obama, and then he made that into this huge thing. So it's based on a little bit of the truth, and that becomes my idea of reference. Okay. And that when they called me to warn me. And that's, of course, what you do, right? That whole thing of the Tiny Tarasoff Act that says you're going to warn people if they are in danger. So they thought that maybe I was in danger. Okay. But if Barack comes to get me, I won't mind. Maybe he'll put me in handcuffs and never mind. So anyway, so one of the other things when we look at full-blown schizophrenia, we look at the positive symptoms. Those are the things that you have that you shouldn't have, and the negative symptoms are things that you don't. Okay? So the positive symptoms of schizophrenia would be those hearing things, seeing things, hallucinations, delusions, things that shouldn't be there. Okay? My negative things are things that should be there. My affect and my mood is all sometimes flat or labile or just not there. I mean, really kind of not. So what you get is like, I'm just flat faced, and that's not a sign of that's not a symptom of the medication. That really is part of that whole schizophrenia. So that's what's missing. The negatives are the things that we miss when it comes to schizophrenia. So that's schizophrenia, and we talked about schizoaffective disorder. We talked about hallucinations as well as my delusions. Okay, so that's kind of the overall school of when it comes to schizophrenia. Questions about that? One of the reasons, so first of all, they're most often not dangerous. I'm not going to say, invite someone in your office who's having a full-blown psychotic episode, but most often they're not dangerous. They're extremely disorganized. You see the homeless people in the cart with everything they own in the cart. Many times that's a sign of schizophrenia because that's all they can get together and keep together, and they keep forgetting where they put stuff. Sad part is schizophrenia, when it's diagnosed between, anybody know what ages?
Is it around 30s?
It's close. It's usually before that, unfortunately.
Mm.
What we see is that, about 18 to 25. We see it sometimes as even younger than that, 15, 16 to 25. And what happens many times is we will see children go away to college and come back, have a psychotic episode, and come back not the same child that their parents sent. And we get that a lot. Like, this is not the child that I sent to college. We do believe there is some, predisposition. You've got some people maybe who have some depression, some anxiety, some other stuff going on, that whole genetic piece. And then the anxiety of school, the stress of school, then really triggers that full-blown, that paranoia many times, and the anxiety makes it so much worse. So if you can see the diagnostics here, okay? So two or more of the following for at least a month. Okay, delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior. The catatonic behavior are people who can sit in the same position for hours and not move. Really bizarre. Like just sit there. Okay, that's my catatonic. Negative symptoms, again, those are things that we're missing. Okay, we have to rule out schizoaffective disorder. And my age, it gives me my age. It's 16 to 25 is what we're looking at. Here we go. Typically between the mid-teens and mid-30s. At the peak onset for the first a psychotic episode in the early to mid-20s for males and late 20s for females. Okay. So again, that's, I've sent this kid to school and all of a sudden, like, whoa, what happened? And, I pick up this kid who's, in the classroom has thought that, the demons have opened up and demons are coming after him. Okay. So that's just the sad with the onset. However, there is a question on the test about later onset. So if you have your first episode after the age of 40, the odds of you recovering are really good. So the later onset, the more likely the recovery. Okay. Medication treatment for schizophrenia, what am I using? I'm using one of my antipsychotics. Pick one. What was that? Haldol, Mellaril, Thorazine. All of those are my newer ones. Include my injectables. I haven't seen them listed by name. If anyone's seen that in their study information, let me know. I just haven't seen that yet. But my injectables are what we're using for many populations that are especially homeless or won't show up at the center as often as they should. One of the reasons that people stop taking it is because they get this lovely side effect, and this is called tardive dyskinesia. You'll see it on the test. It is a central nervous system disorder, and it is a side effect of the antipsychotic medications. They have no control over it. So imagine you're already crazy, really, psychotic, and then you walk down the street looking like this. So that is often, what we see and one of the reasons people stop taking their medications. A couple of questions regarding schizophrenia on the test or psychosis. If a client comes to the hospital and they came because they were in a full-blown psychotic state. 3 days later, they want to leave and they refusing medication, want to leave, and they are not in danger of hurting themselves or someone else. What do I do? Yes, he's typing. So client self-determination does take self-determination. They have the right to leave. They can leave against a medical advice, but if they're not in a psychotic state, they have the right to leave. However, on the other hand, you got it with aftercare plan. You got it. You got it. However, so there is another question that talks about someone who is in an active psychotic state, again, not wanting to hurt themselves, not willing to hurt themselves, not saying they're endangering anyone else, and they refuse to go to the emergency room. What do I do? Or they refuse to go to the hospital. So they're not in danger. They're not in danger of hurting themselves or someone else. So I cannot hospitalize them just because. What's my other choice? They have lost their right to self-determination. So they don't get the right for me to just let them go. Okay, if they're in a full psychotic state, I cannot let them go. Some of the answers are a little strange. It seems one of them is like walk them to the nearest clinic, or if they're if there's a family member, make sure they're in the family member's care. But they don't have that right. They've lost their right to self-determination if they are in a full psychotic episode. Okay, so we got to be careful that we keep them safe. However, we cannot hospitalize them mandatorily because they're not in danger of hurting themselves or anybody else. Okay, I see people typing. Do I have questions? You can just speak, really. Just unmute yourself. Okay. Okay, so schizophrenia, we've talked about. We've talked about schizoaffective disorder. We have talked about my bipolar disorder. We've talked about depression. There's a couple of schools of depression I'm going to come back to cover all those. Let's go to the next question. That's that one. Look at that one. Carl Jung's body of work is most closely linked to what personality assessment? Carl Jung and his archetypes led to what? Yeah, yes, you get the bell. Bingo! Myers-Briggs. My MBTI. Okay, and my Myers-Briggs has 16 categories. Some awful teacher probably made you take it when you were in undergrad somewhere. Okay. Oops. So it is really measuring your personality type. 16 options. Okay, and out of those 16, then you're going to pick 4. So it's a scaling question. You'll do kind of a self-report. You'll answer the questions, and then you'll end up with your letters. An E, an I, an S, an N, a T, an F, a J, or a P. And if you look closely, make it bigger. It's my old lady font. Okay, then it kind of tells you what each of those stands for. So you'll end up with your 4 letters based on kind of what describes you. There's a free one online. If you just Google it, you can find a free one if you've never done one. They're many times used in marriage counseling, pre-counseling to kind of decide like who you are and who you're marrying. I've used them in family therapy sometimes because it's kind of nice for the parents to know the personality types of their children because we have these expectations of how our children should behave, and many times that's not what we actually see. So I've seen that as well. That's my MBTI based on Carl Jung's archetypes. And the archetypes he based them on were anime, animus. Anybody else know? He had about 10 of the archetypes, but we only use 4 of them, the 4 main ones. Okay. And you'll see that the animus, anime, on the inside of us, if I'm a female, inside of me was animus. We all had like a male and female side of us. The shadow, if you see the ma, I remember that always the mother. That's the ma. So the boy always has a ma inside of him and a ma. My shadow, so those lovely, that devil right there, that's the part of the world that we don't want anyone to see about us. The persona, that's that mask we wear for the world to see. And the self in the back there, what Carl Jung said is that we don't know who's back there, and no one else knows, and I don't know either. Things about my personality that I don't know and you don't know. So my MBTI was based on that. Okay. How about some of those others? What's my thematic appreciation test? If you've had me more than once, you should know. Come on, answer. I'm going to have to start talking to Barack, I think. The question was, what is the TAT? The first one, thematic appreciation test. What is that? You got it. Black and white photos. My black and white photos, as well as my Rorschach ink blot test, are things that Freud would use. So if you talk about assessments and how Freud diagnosed, he would take those unconscious thoughts you have and bring them to the top using those things. Freud said, "You poor woman, you know nothing. So let me tell you what you need to know." That is my thematic appreciation test. Okay, and it really is those black and white photos. So you'd lay on the couch, and he mainly treated women. So he'd say, "You poor dumb woman, what do you think?" And then you would look, and he would say, "Well, what do you think he is saying to her?" Okay, and of course, then he would say, "Blah blah blah blah," is what she would say, and he would say, "Well, you're wrong. Let me tell you what it really means." So as a projective, you projected from your unconscious, and then he would tell you what that meant. Subjective. So not a very thorough test, not a very objective test, but worked well for him. The other one was the Rorschach, and that's often the ink blot test. So we'll see that a lot of what that looks like. And my MMPI, what is that one? And doesn't tell me how nice I am. What would it do? Personality disorders. Very good. It tells me your level of crazy. So on the test, it might say personality test, but just know the real personality test of how nice I am and who I am is my MBTI. But my MMPI, there are 556 on the long version, forced choice answers, forced choice questions. Forced choice means yes or no, true or false. So forced choice questions. Okay. And then you would come up with this lovely score of where you belonged on that order. By the way, the MMPI is one of our oldest tests. We're on version 2 revised, but it came right in around the 30s, and it really is. Okay, MMPI 2 is 567 tests, and there's a shorter version that's 338. Again, forced choice, yes, no, And they're written so it's like almost like one of those impulse questionnaires that you just kind of say yes or no really quick, and you're supposed to be able to determine based on those scores if you're lying and then what that score may be. Okay, so first one, you might have hypochondriasis, and that would be, people who think that the burn on their arm is surely cancer and they're going to die. Okay. The second one would be depression, hysteria, a little psychopathology, a little deviant there. If I was too masculine, too feminine, paranoia, etc. Okay. So those are the scales that we would use. So that's the MMPI, the Minnesota Multiphasic Personality Inventory. That's what we use to describe how crazy you are. So don't get that confused with the MBTI, which tells you how nice you are. And that was Carl Jung's Body Works by MBTI. Okay. Skip that one. Trying to explain some of my DSM questions. Okay, not a lot today. Okay, let's go someplace else. Let me close some windows here. Questions, ask me questions. I did mention depression. I was going to talk about that just a little bit more. Let's go back to my cyclothymia, my bipolar disorder. And I jokingly said we have like baby bipolar, but we do have a name now for children who have those mood swings. What's that one called? It's new to the DSM. I see some typing. Okay. So that one's called something about, anybody really? So let's go back to depression then. So when it comes to, we used to have something called, it used to be called dysthymia. And dysthymia was the same kind of thing when it came to cyclothymia. It was the kind of a baby version of my depressive. We've changed that to pervasive mood disorder. So my diagnosis for depression in general, it's most of these things need to happen every day, most every day. That sadness, that loss of interest, some sleep disturbance, trouble thinking, all of those things. Okay. And then, so I know that those symptoms, anybody, how long they need to last? At least almost every day, once a day, or almost every day for a period of at least 2 weeks. So that one's that one. And then my persistent mood disorder used to be called my cyclothymia, my dysthymia. And now that is that kind of low, always going feeling of depression. Okay, so you might see on some of your study guides, you really might see dysthymia. It's just not called that anymore. Okay. We are calling it that persistent. It's just kind of always there. Okay. You see mood disorders. Sometimes you'll see affective disorders, AFFECTIV, affective disorders. That also means a mood disorder. That's really all that means. So whether it's my bipolar, depression, any of those things, it has to do with my mood. Okay. So So that's kind of a reminder then of kind of what we're talking about. That's euphoria and dysphoria. My mania is my euphoria being so high. Dysphoria is the opposite, where I'm very, very low. Okay. So the duration of major depression, my symptoms are present for at least 2 weeks. Dysthymic, again, which is now called pervasive, persistent, PMD, pervasive, that is less severe in symptoms for over 2 years. Okay. That's the history of my disorders there. What are some of my medicines I would take for depression? Give me a good antidepressant. SSRIs is a great title, but what would I get? Prozac? What else? Effexor, Paxil, Zoloft. Zoloft is actually the main treatment of choice for anxiety, but we do know that anxiety and depression on the inside look the same. So many times we'll if someone comes in with more anxiety, then we'll use that Zoloft. There's a question sometimes on the test that talks about the medications. So if I've got someone who has some anxiety, some panic attacks, what medicine would I give them every day, or what could they take every day? And we know my benzodiazepines, for example, my let's see, benzodiazepines would be my Valium, my Xanax, any of those things. The reason I can't take them every day is because they are extremely addictive. Okay. We'll prescribe them occasionally, PRN, for people who have like panic attacks. But overall, we really don't prescribe them. And again, that's my persistent depressive disorder, which used to be called dysthymia. That's what it looks like now. This one I have also, my premenstrual dysphoric disorder. So that one is when I have any of those symptoms around my period, whether it's, anxiety, depression, the mood swings, any of those things that I have can be diagnosed. And it's actually a pretty loose diagnosis. I think that the male doctor is afraid to say, no, that's not it. So it's a pretty loose definition. It's new this time, but it really is those symptoms happening within 10 days up or around your period. Okay. Let me get all those out. Okay, got to there. Okay, so let's go to my NCE book and let's look at some questions from there. Questions, guys? Please ask. I don't mind, really. Close the windows. This book, again, also is really good just for knowledge. It's not as great when it comes to answering the new type of questions, but it's really good just for content when it comes to kind of understanding some of those terms. So as you'll see is most often we'll get a few questions on diagnostic with the DSM and more questions on the approaches. Anyone who's taken the test before would like to share of what the DSM questions look like? Yes, I agree. Thanks. It's a talkative group you are. Thank you. So I'm pulling this up. I'm talking a little bit about personality disorders. What are personality disorders and what makes them so hard to treat? Exactly. So personality disorders, we really believed, are just almost sometimes ingrained from birth. We don't diagnose them until you're at least 18. But if you ask their parents, they'll promise you up and down that that kid has always been this way. They are egosyntonic, which means they're very difficult to treat because people don't come. I don't have a problem with this, so why would I come? The only other things that we think are egosyntonic would be my anxiety. I'm sorry, my eating disorders, my anorexia, things like that. We believe those are egosyntonic because she'll never say that she's thin enough. She's always worried about being fat. So those are things that we worry about as well. But in general, let's just go over some personality disorders. You heard that the difference in the exam, I heard they may ask the difference between bipolar 1 and bipolar 2. I went over it a little bit already. If you want to go back and kind of rewatch the video, the difference is the time frame. In my bipolar 1, I have at least 5 to 7 days of that full-blown mania. And then in my bipolar 2, it's 2 to 4 days with hypomania. So I'm not necessarily near as high. But at the end of here, we get the videotape will be here. I'll upload it to YouTube later, maybe about 2 weeks, 3 weeks from now. But if you want to see it now, it'll be here. Okay. So in general, we don't divide them into clusters anymore, but you just really want to kind of make sure that, and some people love them in clusters because it's easier to remember. Okay, and I'm a picture person. I think many of us can, you can read, whether it's whoever you're reading, it's great to read, but I'm a picture person. So it looks like personality disorders. I don't want to sign in. Okay. So, if you haven't had me yet, let me tell you that antisocial personality disorder is often used in the media. It does not mean that they don't like people. They do like people. They like to eat you and kill you. They'll invite you to your house and they will stab you and they will choke you and then they will tell you it's your fault. So just remember, they are really, really, really pro people. Yes, they have you for dinner. But so what we know is those conduct disorders, conduct, which is that you're labeled before the age of 13. They're the ones who kill animals. They will feel no remorse. So untreated, my conduct disorders many times are ending up as personality disorders. We do know again that they don't see a problem with it. They don't come to therapy because they don't have a problem. Egocentric, in sync with their ego. Okay, so there's autocentric. Those are my dramatic and my erratic behaviors, as well as my anxious and fearful. I'm gonna let you look at that, guys, just for a minute. I've got to get a drink of water, so give me 1 second. I'll be right back. Okay, can someone tell me all those things and what they mean? I walked away for 5 minutes. You should be able to tell me, right? I apologize. I just had to get a drink of water really quick. I do teach all day, every day, and at some point I get extremely parched. So my cluster A are my odd and my eccentric people. That just means my weirdos. My paranoid personality disorders, I think that's pretty easy. They're afraid of, someone's looking at them, someone's coming after them. Um, Somebody put something in their drink. That's really actually very common to go along with my people who have, you can have both. Let me back that up. So what we used to have is we used to have the second axis. So on the first axis, you could have schizophrenia, and the second one, you really could have then a personality disorder. So it would not be uncommon for someone to have schizophrenia and then have a paranoid personality disorder. So that would not be uncommon. Personality disorders, again, many times we are not treating them with medication because, again, they don't have a problem. So my paranoid people, I think you can imagine what that's like. My schizoids and my schizotypal, many people get those confused. Anybody want to take a shot of how different they are and what they look like? My schizoids, they are the ones who are avoidant, little weird, not hugely weird, but really they would go to a party and they would, sit in the corner by themselves and not have a problem. Really not. They'd be just okay with it. I like this one. The page through there. There we go. So my schizoids, so his only friend is the fish, and he doesn't even want the fish around. They're voluntarily socially withdrawn, limited emotional and expression. They're the person in the corner by themselves. They're not having any hallucinations. They're not having any delusions. It's a personality disorder. It's who they are. And again, looking back, if you ask their mother, they would say, well, little Bobby's always been this way. And little Bobby has just really had void of friends and doesn't mind it. He doesn't mind it. My schizotypals, you'll see, those are my little weirder, okay? They have more of the schizophrenic personality or the symptoms. I always say they're more typical of a schizophrenic. Okay? Again, we're not having any hallucinations or any of those delusions, but definitely some weirdness, interpersonal awkwardness, superstitious, eccentric behavior. You see him, he's saying, always keep some toast in your pocket. You might see, I have a client who would wear earmuffs over his ears all winter, all year round because it was easier to keep down the things people were saying about him. So you see the bizarre dress, the bizarre behavior. That's what you see more with my schizotypals. So they are more likely to look like typically like a schizophrenic. That's what that one looks like. Okay, so schizoids, schizotypal, and paranoid all belong in the same cluster. Is there a higher risk? Actually, no, there's not. We diagnose schizophrenics. We diagnose these personalities at 18, so you can, but not always, and not necessarily a correlation. So no. And as with most diagnoses, we really don't know the cause. We don't know. There's a genetic piece. Definitely my mother was depressed. My father was depressed. We believe there's a genetic piece, but we really don't know what the cause is. And again, you wouldn't see one of these in treatment unless someone made them or there was something else going on, because since they don't have a problem, why would they come for treatment? We think they're weird. They've always been this way. So again, that was my type A. My cluster B, you're welcome. My cluster B, those are my borderlines, narcissistic, histrionic, and antisocial. And I think I've shared with you already what those lovely antisocials look like. They really are, they have no regard for human life, no regard for no forgiveness, no remorse. They're the ones they're really the ones you see on TV. We think about like the Unabomber. We believe that he was truly antisocial. He lived in his little place in the woods. He did have a job at some point, but he really thought there was like no place in mankind for some people, and no remorse, none whatsoever. We needed to get rid of them. The world was a better place without them. Jeffrey Dahmer, yes, because he ate people. Ted Bundy, he was the Florida killer that was so charming. That he's one also that we gave him an antisocial personality disorder. So you can be a sociopath. That's kind of what we think that term we use, but we're thinking about an antisocial personality. Looking back, their mother would say, yeah, he was killing animals, or, he was doing this when he was 3 and 4. Okay. To go back a little bit and try to throw some things in, when we talk about our killer in Florida, one of the things that made him so easy to get in the car with was his charm. And that is called the halo effect. So like a halo on my head. The halo effect says that we believe people who are more good looking, more charming, we're more likely to buy things from them or help them. I think he used like the puppy ruse, or he had a broken leg one time and please help me. And women, of course, would believe him, and then he would, kidnap them and murder them. But that's the halo effect. So anyway, my histrionic personality disorder, I usually tell my ladies, if you don't have a girl in your friend group that's histrionic, it might be you. She's the one that when you go out, she is just a little bit extra special. She likes a little bit of attention. She's got the little skirt on, the high heels. Look at me, look at me, look at me. I'm not asking you to diagnose yourself. I'm just saying, look around your friend group. And if everybody else is wearing jeans and tennis shoes, and this is how you need to dress, just maybe you're histrionic. And it really is about getting lots of attention. I need to be the, her. Are you sure you're not her? Again, in your friend group. But so really, they like lots of attention, extravagant. They are not mean, but very much attention seeking. One of the things you'll see as many times that population gets older, if you've gone out to dinner with your grandmother and her friends, and everything is awful, they're sending everything back, they're flirting with a young waiter, all of those things are pretty much a histrionic personality type. The soup is too hot, it's too cold, please get the manager, I want my fruit, all those things. Yes, exactly, Blanche. That's my histrionic. And again, personality disorders, ingrained, not changing. They have no problem with the way they are. And if you said to her, what's going on with you, she'd be like, what do you mean? Okay. So histrionics. Now, many people will say that my narcissists are the male version of a histrionic, and that's really not true. My histrionics really aren't mean. They're not about hurting anyone else. They just need to be the center of attention. That just needs that's like, look at me, look at me, look at me. My narcissists, which come in men and women, we're just most often seeing it in men. And I think that there's some part of in men, and I don't want to insult anyone, men, I don't have any men today, but there's some part of men that is generally a little more selfish than women. So I think it's easier for a man for us to see that in men. One thing that makes them, that you'll know, is that they, on the test at least, they actually have low self-esteem. So what they're putting out is not what they're feeling. Okay, so the narcissist is all about him. The sun rose this morning because of them. Okay, and there's a correlation between like people who have lots of empathy and men who are narcissistic. Our empathy people just really feel sorry for them and want to fix them, and my narcissist people enjoy that. Take all of me. Shoot, yes, because it's about me. Their children and their family are just collateral. If you get to be in the same room with them, be thankful they let you breathe the air. Yeah, but that's the outside. On the inside, they really, really are very unsure of themselves. So if you can see this one, if you have a person, if you're affected by a narcissist, they shower you with gifts or attention so you can forgive and forget their negatives. They charm others. This person's amazing, but they never show their true colors unless alone with you. They berate you, demean you, belittle you, humiliate, embarrass you in front of others, very controlling. Everyone assumes they assume it's someone else's fault. Everyone else is crazy, not them. They try to isolate you, keep you from their friends. They bring up lots of things from the past. So all of those things are my narcissists. So those would be not necessarily my physically abusive people, but psychologically or emotionally abusive. And again, you are lucky to be in the same room with them. Would never go to therapy. They might have been married 6 or 7 or 8 times, but it's not their fault. So if the person had been good enough, smart enough, blah, 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 then the narcissist would have kept them. Okay? Again, not going to treatment. If I go, because that wife made me go, but I don't have any problems. Then I think the borderlines, all black and all white. Okay? They're the ones who love you, love you, love you, love you. If you get one in therapy, they will come in and tell you, I've had 17 therapists before I met you, but you are the best. I'm so thankful. They were all awful, but you are amazing. And they've known you 3 sessions. And they will, again, tell you how amazing you are. Until you say the wrong thing. Exactly. Exactly. Or wear the wrong color or show up 10 minutes late. Whatever. So exactly. Then they're going to leave. So yes, and they feel good in the beginning. Oh my gosh, because they will just say, you're the best. Oh my gosh, I've never had therapists like you before, blah, 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 blah. Most often, they're not going to let you have their records. If you ask for a release of information, they're not going to let you have their records. Like, no, because he was just a horrible therapist. You don't need to know. But again, so that it's called splitting. And if we look at those defense mechanisms, splitting is what borderlines do. You're all good or all bad. There's no in between. Okay? So very black and white, no gray. So that's my narcissist, histrionics, got those. Okay. My last ones are my avoidant personality disorders, my dependent, and my obsessive compulsive. My avoidants, they're unlike my schizoids because they really like people. They're just afraid of being judged. They really want to be with you. They think you're great. They're just afraid you'll think bad things about them. Most often very inward, not willing to share a lot about themselves because you might find out how weird they are. That's what they're worried about. My dependents, of course, you've seen. They're the ones, whether it's a husband, wife, or a mom or a dad, they can't make a decision without you. My dependent should be married to my, my narcissist, because, she would just listen and he would tell her what to do, and it worked out well. Then my obsessive compulsives. So that's a really good one to kind of talk about the difference between a personality disorder and not a personality disorder. So if you look at OCD versus OCDP, you see what the real difference is. In general, OCD it's my obsessive compulsive disorder. So my obsessions are my thoughts. My obsessions are, oh my gosh, my hands, you can see the germs on my hands are awful. I can't stand the germs. I've got to wash my hands. I touch something, got to wash my hands. Those are my obsessions over and over and over again. I hear those obsessions in my head. In order to fix those obsessions, then I'm going to wash my hands. That's the compulsion part of it, okay? Thoughts, hands are dirty, 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 dirty. Obsessions, compulsions, wash my hands, wash my hands, wash my hands. So it looks like. It is, it's actually the same category of hoarding disorder. It is, definitely one of my anxiety disorders. And if I have OCD, I will probably come get something done about it, because I don't like it. I don't like it. It's interfering with my life. So if you can see the difference, my OCD disorders, those symptoms vary in severity over time. My OCDP, remember, they've had it their whole life. So the symptoms are probably going to stay the same. Again, you can ask the mom. The mom will tell you when Johnny was 7, he had to he had to take, showers for 3 minutes, or he had to walk around the car 3 times before he would get in. Ingrain who they are, personality, but not diagnosed until 18. So an OCD, if it's my form of my anxiety disorder, it's easily identified because I don't like it. The word is ego dystonic. I don't like ego dystonic. Okay. My OCPD cannot be easily recognized because it's part of my personality. Okay. You've been seeing me do it for years, so you don't think it's strange. I have my neighbor across the street. We've lived here for about 15 years now. I live in a cul-de-sac, and she's always concerned that she's going to leave her garage door open. So instead of making a left going out to the street, she makes a right. She closes the garage door. She'll back up, watch it close, and then drive through the cul-de-sac, come back around, and stop and look to make sure it's closed. Okay. If I had to guess, I would say it's the OCD, the personality disorder. It's just because it's ingrained. It's who she is. That's just what she does. I really thought she had pretty flowers, and I hadn't been close enough to her house. And every year she has amazing ferns. I found out a few years ago that they're plastic. Like, oh my gosh. So I think that's part of her personality disorder, is having this beautiful, perfect, lawn and front yard, but they're plastic. So maybe I'm the stupid one because I didn't realize till years later. She puts them in her garage and she hangs them back out. So. I would agree with that. Of course, I don't do well with flowers, but I don't know. Anyway, so then the motivation to change. So the motivation to change for my OCD people is usually there's something going on. They don't like this. They feel like if they don't wash their hands, they'll catch the coronavirus and they will kill their entire family. So something awful will happen if I don't stick with my obsession, my pattern. And it's not like someone breaking into my house. It's usually something catastrophic would happen. They'd break in my house, steal all my stuff, put it on TV, and everybody would know my business. I mean, something really bizarre. So that's why they come to treatment, because of those really bizarre thoughts. My OCD people, they just they need to be perfect. They just have to be perfect. Many times the question will talk about them having a need to be so perfect that they lose their job, because everything has to be done perfectly. If you have a report due the next day, it has to be done perfectly. Okay. Again, my OCDs, they're able to, seek medication for their help. My OCPD, personality disorders, they are not. They're not coming for help. They seek help due to everyday conflicts with family and friends, because somebody else is blaming them or telling them to get it together. So that's the only reason they come. So in general, most of my personality disorders are like that. They really, really are not coming. And the words I've used, I think, is ego syntonic and ego dystonic. Okay. And I always remember that ego syntonic is in sync with who I am. Ego dystonic, I don't like dys. Okay. Sometimes we'll see ego alien, which is the same as ego dystonic. So ego alien really means that you're trying to make it foreign to my ego. Because my OCDP is normal for who I am, if I can get you to look at it and realize that it's not okay, it becomes ego alien, and then therefore ego dystonic, and you might seek some treatment. Okay, so that's those personality disorders look like. Okay, questions on those, guys? Those are my major disorders. Ask me something else. Ask me some of the others that you've seen, you've studied, and you think you might be on your test. We have that gender dysphoria. Has anyone seen that on the test yet? I've seen it on the other test, and I'm thinking it might pop up at some point on the NCE exam, just because the social workers, they're using it. So let me just tell you what those look like. Gender dysphoria has to do with so euphoria is I'm good with who I am. So euphoria is my happiness, all that good stuff. So if it's dysphoric, then I am not liking it. It's not comfortable for me, so I don't like it. So I believe if I'm gender dysphoric, I can pull it up there. My Word doc. Okay. So if I have gender dysphoria, then I do not like the gender that I am. And gender is not sexual orientation. It's whether I'm male, female, or binary. I can choose to pick neither. You can put an X on that baby's birth certificate these days, and you don't have to pick a sex, and that's called non-binary. So the term intersex is a term we used to use for hermaphrodites, people who are born with both of those sexual organs. They may have some parts of boys and some parts for girls. So that's called intersex these days. I get my thing to open. And then gender assignment is what I was born with. That is what I was born with at birth. So if I have a penis, then according to the terminology, then my gender assignment would be boy. However, people think that they were born with the wrong gender, so sometimes then they have gender reassignment because they're uncomfortable with the gender that they were born with. There. The difference between a transsexual and a transgender would be what? I saved it someplace else. That's probably why. Anything? Transgender and trans. So my transgender means that I have not had reassignment yet, but I am feeling like that I am of the other gender. So I may dress like a female. I may look like a female. I may act like a female, look like a female, bind my my penis to the inside of my leg. I've seen women who bind their breasts because they definitely want to appear to be male, and they haven't had surgery yet. So the gender reassignment, once I have the surgery, then I am considered to be transsexual. So then I may have been born a man. I have had a gender reassignment surgery. So now I am viewed as a female. Okay. Again, nothing to do with your actual sexual orientation. So the question might talk about being born a male, being a female, being born a male, being a female now, and you choose to sleep with women. So the question is regarding your sexual orientation. So at that point, you may be a lesbian. So just know those terms, transgender and transsexual. That's that T in the LGBT population. So that's the gender reassignment, all that good stuff. Stop sharing here. My camera will open. Guess not. Okay, ask me some other questions. The DSM is huge. There's 1,000 and things in there. Hoarding disorders, one of the new ones we see. In copresis is poop. I poop on myself. In uresis is when I pee on myself. Those are things that are in there sometimes. There's something called rumination disorder that is under my eating disorders. Pica is when I eat anything that's not food. And rumination is when I swallow, chew my food, chew, swallow, don't quite swallow it, pull it back up and chew it again. That's a rumination disorder. My bulimics, they're the ones that I'm going to overindulge and then throw up. Bulimics are normal size. You would not know that. My anorexic on the other side, they are, many times very, very small. Can I talk about changes with AS? Do you mean autistic syndrome or Asperger's? Is that what you're meaning? Gotcha. Okay. So what we know now is it's a spectrum. So I told the kid the other day that, his diagnosis wasn't in the DSM anymore, and he wasn't happy with me. Well, he wasn't a kid, he's an adult. In general, when it comes to these type of disorders, we have cognitive. So we have neurocognitive, which would be my dementia, Alzheimer's, things that happen in my cognition in my brain. And I have neurodevelopment, things that happen as my brain develops. So autism disorder is a brain, it's a development disorder. And there's lots of course, talk about people that the issue comes from, the vaccines we use. I'm not going to take a stand on that. I'll tell you the test doesn't agree with that. So you can, it's on the spectrum now. If you have some Down syndrome, cerebral palsy, many of those things that are quite evident at birth, but you might not necessarily see those things later. So those are my neurodevelopmental disorders. So what we know now is there's just a spectrum. We have taken out the high functioning, low functioning, all those things when it comes to autism. No problem. I'm a college professor. My students know you can never use Wikipedia. But if you really want really cool, fast information, it's just so cool. It's actually a lot more reliable than it used to be. Still can't use it for a research paper. Okay. So then what we did is we took a whole group of those disorders and we kind of clumped them into one disorder. So it used to be we'd had this whole kind of low functioning, high functioning, pervasive development disorder, and now we have a spectrum. And the spectrum means that you are somewhere between very low functioning or all the way into what we used to call Asperger's, which are very high functioning people. In general, my autistic children are not low functioning. They have verbal issues, or it's difficult to communicate with you. But most of the time, they really are able to function at a relatively normal IQ level, which, by the way, is 100, between 91 and 109, with standard deviation, whether you're taking the WAIS, the WISC, or the WIPSI. So just so you know that. So anyway, so it includes autism and spectrum disorder. Like I said, they're neurodevelopmental disorders. We really don't know the cause. Again, we have lots of speculation, but we do know the cause. It is more common in girls than it is in boys. So we used to have also PDD on there, pervasive depressive disorder, pervasive developmental disorder. We used to just give that to kids who are developing slowly, and we didn't really know why. So I had a psychiatrist one time who just called that funny acting kid. So we just kind of didn't know why. So that was what we used for that one. But now we know when it comes to diagnosis. I'm just going to talk about that. The characteristics in general, no matter where you're on the spectrum, we're looking at sensory issues. A kid who likes to play by themselves, who doesn't make eye contact. Those are my low end. My high end, but according to the diagnosis, it doesn't change anymore. We're just looking at autistic spectrum disorder. So I'm not going to necessarily minimize or talk about where they are on the spectrum. They oftentimes play with cars. Is that the picture? They play with toys differently than other people would. He's stacking cans, but sometimes they'll stack cars instead of play with cars. Okay. We usually diagnose it by the age of 3. There's a test on the test that asks how we know, or what's the first kind of what we look for when we're looking for this kind of disorder, and it's usually a language. So before they begin to speak, sometimes we'll notice them avoiding eye contact. We'll notice them maybe playing cars a little differently. They're not often soothed by mom's touch, but it's not until that language development comes that we're really actually fully diagnosing them. Okay, it's lifelong. Really is. There's not. Sometimes we'll do some attention deficit, those type behaviors, or hyperactivity. So we'll put them on some Ritalin, some of those kind of things. But in general, there's not a medication that we would use for it. What else? Okay, behavioral characteristics. Difficulty creating connection with others, with other people. They develop difficulties in creating these. They don't see a need for the connections. They're fine by themselves, so they just don't see a need for that. Okay. It follows a normal developmental course. Parents report the onset within the first year of life. We usually don't diagnose them that early, but we have. The symptoms more gradual in nature. Parents then are concerned. What I tell my clients now, and I'm old. I'm 54. So when we actually first started seeing autism, we really thought that kids had the language and then lost it. And of course, that was based on parent reports, because parents would swear up and down that kid was talking, and suddenly, they're 5 in kindergarten and not saying anything. So now we know that's really not true. They didn't have language and lose it. They just didn't have it before, and maybe mom and dad didn't notice. Okay. What else? They are a second course of developmental is characterized by near or near normal development by the first between the age of 15 months to 3. And then we have the onset with the regression of the loss in skills. Okay, so that's what we see sometimes, but we really don't think that many of them are that verbal prior to that age. Talk about the social skills. They really kind of don't. They don't play with others. Part of the training is a social skills training and learning of how to deal with those social skills. We know, again, on the spectrum, many times they don't do well with change. Cannot see my screen. I bet I stopped sharing. Thank you. I did. I stopped sharing. Thank you. Okay. I'm using Wikipedia. Okay, I'm looking over the autism spectrum disorder. Thank you for saying something. Okay. So again, talked about kind of the signs and symptoms, the behavioral characteristics, the developmental course, a lot on social and communication skills. So that's the biggest issue is children can't communicate and they become very, very, that's always the behavioral issues is because they can't communicate. And that whole issue with change, they're very much used to routine, and that change often really kind of sets off what, my friend would say is he's having an episode. So learning, preparing the working with mom and dad to get them used to the routine, and then learning to protect the kid and protect them with change. So help them prepare for the change. Communication deficits include challenging with verbal language skills. They are what else? Complex. They have complex pragmatic language. That just means they don't really. We don't know. They're not verbal, so we're not really sure how much that. Oftentimes they understand. They do not pick up on body language or social cues. If you've ever seen that, that you're talking and talking and talking, and they keep talking to you, and you're trying to walk away, and they'll keep following you. So many times that behavioral approach with that group will really look at just kind of making sure that you learn those social cues. If you've ever seen someone with autism, an adult with autism who's had some skills training, it looks very forced that they know to shake your hand because they've been taught to shake your hand. They've been taught to look in your eye. So they've been taught the social skills. However, it doesn't come natural. Other questions? Okay, guys, I'm going to wrap it up. Like I said, the recording will be here at the end. When I sign off, it'll be there. I'll place it on YouTube probably maybe about a month from now-ish. However, if you're unable, it'll be here for 30 days. If you're not able to save it, be sure that you let me know and I can try to send you a link at some point. But if you log back into this group, the Skype group, it will be there. If you log back in also and you've not been here before, you can probably see some of the other videos. They stay in this chat room for 30 days. Okie dokie. Other questions? I plan on having a great weekend. Thank you. You guys too. Hope you had a great Valentine's Day. No matter if it was with the one you love or the one that you don't love. It was just fun. Bye, guys.